Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Good morning, Dr. Thompson. I came in because my legs have been bothering me more than usual, and the numbness is getting worse. It started in my feet years ago, but now it's moving up to my knees. I've lost a lot of sensation in my hands, too.
Good morning, John. It's important that we review these changes thoroughly. Can you tell me more about the progression of these symptoms?
Sure. I first noticed the numbness in my toes back in 1998, and over the years, it just crept up to my lower legs. Recently, I started feeling it in my knees. My hands began to lose feeling about 5 years ago. It's like I'm wearing gloves all the time.
I see. You also mentioned some issues with your right wrist. Could you elaborate on that?
Yes, it swells up a lot, and sometimes it's really painful. My doctor said it's gout and edema. I've been on allopurinol for the gout, and we've adjusted my furosemide for edema recently because of the swelling.
Has there been any improvement with the adjustments?
A little, but it's hard to tell sometimes with the other issues I have going on. The swelling does go down, but it comes back.
And you had a spinal tap recently?
Yeah, that was tough. They tried several times before they got it right. They're looking into what's causing the neuropathy. I'm waiting on those results.
Understood. We'll review those results as soon as they come in. How about your general health otherwise? Any changes in your daily activities due to these symptoms?
Well, because of the numbness and pain, I'm not as active as I used to be. I get tired easily, and I have these periodic fevers and chills. My doctor thinks it might be related to my kidney issues.
Speaking of which, I see here that your kidney function has been a concern. Can you update me on that?
Yes, my kidneys have been a problem for a while. At one point, they said I was at stage 5, but now it's more like stage 4. We're trying to manage it the best we can.
I appreciate your thoroughness, John. Let's go over your most recent lab results and see what our next steps might be. Blood pressure, 138/85 mmHg, creatinine 2.1 milligrams per dl, EGFR 35 millinine 1.73 millisquared, C-reactive protein elevated at 4.8 milligrams per, which could be an indicator of inflammation or infection. Your lab results show your kidney function is stable compared to previous readings, but still requires close monitoring. Your creatinine is elevated, which is consistent with your chronic kidney disease. The C-reactive protein is a bit high, suggesting some inflammation, which might be tied to several of your conditions.
What do we do next, then? I'm really worried about all this, especially with my history of polyps and everything else.
I understand your concerns. Here's what I suggest. First, We need to keep a close eye on your kidney function and adjust your treatment as necessary. I want you to monitor your blood pressure at home and record the readings. We should also consider another nerve conduction study to compare with the last one. Regarding the polyps in your colon, given your family history and the frequent occurrence of polyps, I agree with your previous doctor's advice not to wait too long for the next colonoscopy. Let's plan for that in the next 6 months. For your neuropathy, depending on the results of your spinal tap, we may need to adjust your treatment. It's also essential that we manage your symptoms to maintain your quality of life.
That sounds like a plan. I just hope we can find something to help with the numbness and the pain.
We'll do everything we can. Let's schedule a follow-up in 4 weeks to review your spinal tap results and see how the adjustments in your medications are working. I'll also coordinate with your renal clinic to ensure we're all on the same page.
Thank you, Dr. Thompson. I appreciate you helping me keep track of all this. It's a lot to manage.
You're not alone in this, John. We'll work through it together. See you in a few weeks.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I've been noticing a lot of changes in my health that are concerning me. The first thing is my weight. I've actually been skipping breakfast to try and prevent gaining more weight, but it doesn't seem to be working. I've been gaining weight regardless, and it's very frustrating.
I see. That must be quite frustrating for you. Have there been any changes in your lifestyle or routines aside from skipping breakfast?
Not really. My routine is pretty much the same, but the weight just keeps coming. And there's another thing that's been worrying me a lot. My stool color changed drastically a few times. It started off black, then turned green, and even topaz before going back to normal. I remember reading somewhere that black could mean bleeding in the gastrointestinal tract.
That's correct. Black stools can sometimes indicate bleeding in the upper gastrointestinal tract. Changes in stool color can be concerning, and it's good that you've noticed and mentioned these changes. What about your sleep and your overall mood lately?
Oh, sleep has been rough. I find myself struggling to fall asleep, and when I do, I can only stay asleep until about 3 in the morning. I've been using Advil PM to help, but it's not ideal. Emotionally, it's been tough too. I've been feeling quite down, lacking interest in things I used to enjoy, and sometimes I even have disturbing thoughts about harming others. It's all quite overwhelming.
It's important that you shared that with me. Thank you. Dealing with sleep disturbances and feelings like these can definitely take a toll on your overall well-being. Regarding your breathing, have there been any changes or worsening symptoms there?
Yes, definitely. My asthma seems to be getting worse. I use my Advair and albuterol inhalers, but especially during the early mornings and when it's hot, my breathing really struggles. It feels like my current medication isn't enough anymore.
Managing worsening asthma symptoms can certainly be challenging, especially when they disrupt your daily life like that. Have you noticed any triggers or patterns that seem to worsen your symptoms?
Mainly the weather changes, and sometimes after I visit my parents. They're both not in the best of health, and caring for them adds a lot of stress, which seems to trigger my mood swings.
That sounds quite demanding. Caring for elderly parents can be stressful and could indeed contribute to both your respiratory issues and psychological distress. Let's make sure we address all these points today. I'd like to review your medical management comprehensively and perhaps adjust some of your medications. We should also consider therapy for your psychological distress, as it seems to be impacting your quality of life significantly.
I think that would be good. I just want to feel better and manage these issues more effectively.
Understood. Based on everything you've told me, here's what I think we should do. First, I'd recommend a psychiatric evaluation because of your high score on the depression screening. Starting sertraline could help manage your depression symptoms, and arranging regular therapy sessions will provide additional support. For your respiratory issues, we might consider adjusting your asthma medications and possibly adding tiotropium to help manage your symptoms better. Given the variability in your stool, we need to monitor for further episodes of discolored stools and investigate potential gastrointestinal bleeding. I'll schedule some laboratory tests, including for diabetes and cholesterol, since you've experienced recent weight gain. We'll also review all your medications, including omeprazole, and discuss new prescriptions as needed. Lastly, it's important that we schedule regular follow-ups to monitor your chronic conditions and adjust our treatment plan based on your response to these changes.
Thank you, Doctor. It sounds like a comprehensive plan, and I'm hopeful that these adjustments will help me feel better. I appreciate your help.
You're welcome. It's important to address all these issues to improve your quality of life. We'll work together on this. I'll make sure our nursing team schedules your follow-up appointments and helps coordinate the new treatments. If you have any questions or if there's anything else you need in the meantime, please don't hesitate to contact us.
Will do. Thanks again for your thorough approach and understanding.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
We need to review the protocol for the central line insertion to ensure we're both clear on the procedure. Have you checked the latest guidelines?
Yes, I've reviewed them. The first step is to ensure the patient is properly positioned, which reduces the risk of complications. Are we using ultrasound guidance?
Absolutely. The guidelines now strongly recommend ultrasound guidance to increase accuracy and reduce puncture attempts. Do we have the ultrasound machine ready?
It's all set up. I'll handle the machine and you can perform the insertion. We also need to remember to maintain strict ASEP technique to prevent infections.
Right. I'll make sure the full barrier precautions are taken. Once the line is in, we need to confirm placement with an X-ray before using the line. Does that sound good?
That sounds perfect. Let's also ensure we document everything accurately.
Now look at question 26.
Welcome everyone. Today we're focusing on ensuring the correct route for each medication, a fundamental aspect of patient safety. Let's start with oral medications. They are the most common route and must be used when the patient can swallow safely. Moving on to IV medications, these are used for faster action, and it's crucial to check the IV site for signs of infection or phlebitis before administration. Always verify the medication compatibility with the IV fluids. Lastly, let's discuss inhalation routes, particularly for medications like bronchodilators or steroids. Ensure the patient knows how to use inhalers correctly and always check the technique to maximize the therapeutic effect. Double-checking the route not only maximizes the efficacy of the medication, but also minimizes the risk of complications. Thank you for attending, and always remember, right route equals right results.
Now look at question 27.
Hello, Mr. Thompson. I understand you're experiencing some pain today. On a scale from 0 to 10, with 0 being no pain and 10 being the worst pain imaginable, how would you rate your pain right now? Okay, you've said it's about a 6. Can you describe the pain? Is it sharp, dull, throbbing, or something else? It's a sharp pain on your left side. Thank you for that information. Has anything helped to relieve the pain, like medication or a certain position? No relief from over-the-counter meds, I understand. Based on your feedback, I'll consult with the physician for a pain management plan. We'll get you feeling better soon.
Now look at question 28.
Good morning, everyone. Today's topic is patient autonomy, an essential principle in healthcare. Patient autonomy respects the patient's right to make decisions about their own health, including the right to refuse treatment. It's important for healthcare providers to ensure patients are fully informed. This means explaining the risks, benefits, and alternatives of treatments in a way that the patient can understand. Let's also remember that respecting autonomy means we support patients' decisions even if we don't agree with them. Our role is to provide the best information and support possible. Fostering autonomy enhances patient satisfaction and can lead to better health outcomes. Let's strive to respect and uphold this principle in all our patient interactions.
Now look at question 29.
Mr. Davies, given your current symptoms and the progression of your condition, we need to transfer you to the ICU to provide you with more intensive support.
What exactly does that mean for my care, doctor? Am I going to be okay?
In the ICU, you'll be closely monitored 24/7 by a team of specialized healthcare professionals. This level of care will help us manage your symptoms more effectively and adjust treatment as necessary.
I'm a bit scared. Will my family be able to visit me there?
I understand it's a bit daunting. Yes, your family can visit during designated hours. We'll do everything we can to make you comfortable and keep your family informed every step of the way.
Now look at question 30.
Today, we're going to discuss patient-controlled analgesia, or PCA, a method that allows patients to manage their own pain post-surgery or during severe pain episodes. PCA devices are programmed to deliver a preset dose of pain medication when the patient presses a button. It's a safe way to manage pain, as it has limits to prevent overdose. One of the major benefits of PCA is that it provides patients with control over their pain management, which can lead to greater patient satisfaction and often better pain control. It's crucial, however, to educate patients on the use of the PCA device to ensure they understand how and when to use it. Proper education reduces the risk of complications and improves outcomes.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at extract 1.
Hello everyone, and thank you for joining today's session on the complex interplay between long COVID and chronic fatigue syndrome, CFS, also known as myalgic encephalomyelitis, ME. Today we'll be diving deep into the pathophysiology, clinical manifestations, and emerging therapeutic strategies, using insights from recent research and case studies to enhance our understanding. The discussion of post-viral syndromes is not new in medical literature, but the scale and urgency have been magnified by the COVID-19 pandemic. Long COVID presents with a mosaic of symptoms that persist long after the acute viral infection subsides, affecting millions globally. To better understand long COVID, we can draw parallels and distinctions from CFS or ME, a condition similarly triggered by viral infections and characterized by profound fatigue, cognitive dysfunction, and worsening of symptoms post-exertion. Our exploration begins with a case study from a Harvard research article. The patient, a 45-year-old female former marathon runner, developed long COVID following a mild SARS-CoV-2 infection. Initially presenting with fatigue and shortness of breath, her condition evolved into a more debilitating state characterized by cognitive disturbances and severe physical limitations, reminiscent of CFS or ME. This patient's journey highlights the often disabling and fluctuating nature of post-viral syndromes. Pathophysiologically, long COVID and CFS or ME share several mechanisms, yet there are unique aspects to each. Both conditions have been linked to persistent immune activation, autonomic dysfunction, and possible small fiber neuropathy, which could explain the wide array of systemic symptoms. Additionally, the role of chronic endothelial dysfunction, as highlighted in recent studies, suggests a vascular component to the symptomatology, particularly in long COVID, where microclot formation and impaired microcirculation have been observed. Clinically, both long COVID and CFS or ME present with a core symptom of post-exertional malaise, P, a worsening of symptoms following even minor physical or mental exertion. This hallmark is crucial for diagnosis and management, as it differentiates these conditions from more conventional chronic illnesses and informs the pacing strategies that are central to patient management. Emerging treatments for long COVID and CFS or ME involve a multidisciplinary approach, integrating pharmacological and non-pharmacological therapies. For instance, studies suggest that using low-dose naltrexone may help modulate the immune response in some patients. Similarly, cognitive behavioral therapy, CBT, and graded exercise therapy, GET-T, have been controversial, but are used under specific conditions to improve functional status without exacerbating symptoms. However, as we delve deeper into research, the limitations of current therapeutic approaches become apparent. For example, GET, which is effective in some chronic illnesses, can potentially worsen outcomes in CFS or ME and long COVID if not administered with careful monitoring of patient tolerance. This has sparked significant debate and calls for personalized treatment plans based on individual patient responses and the dynamic nature of their symptoms. The intersection of long COVID and CFS or ME represents a complex challenge in modern medicine, necessitating ongoing research and flexible clinical approaches. By integrating case studies like the one discussed and leveraging emerging research, we can enhance our understanding and improve the quality of life for millions suffering from these debilitating conditions. I look forward to your questions and a robust discussion on how we can further refine our approaches to managing these complex post-viral syndromes.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome to today's healthcare podcast, where we delve deep into the complexities of diagnosing and managing skin and soft tissue infections, particularly focusing on necrotizing fasciitis. This condition, often referred to as flesh-eating disease, is a serious bacterial infection that spreads rapidly and destroys the body's soft tissue. Today, we'll discuss a particularly challenging case that highlights the critical aspects of diagnosis and treatment. Let's begin with a case study from a recent encounter in the emergency department. The patient, a 55-year-old male with a history of diabetes and obesity, presented with severe pain, swelling, and redness in his left lower leg. He noted that the symptoms developed rapidly over 24 hours, progressing to include blisters and a darkening of the skin. Upon examination, the patient was febrile with a temperature 8.7 degrees C, hypotensive with a blood pressure of 90/50 mmHg, and tachycardic with a heart rate of 112 beats per minute. Physical examination revealed a tense, swollen leg with areas of purpura and bullae formation. The rapid progression and severity of the symptoms raised an immediate red flag for a possible necrotizing infection. Given the patient's clinical presentation and history, the first step was to stabilize him while preparing for further diagnostic evaluation. Intravenous fluids were initiated to address his hypotension, and broad-spectrum antibiotics were administered to cover likely pathogens, including MRSA and Group A Streptococcus, which are commonly associated with necrotizing fasciitis. Simultaneously, imaging studies were urgently pursued. An X-ray of the leg was initially performed to look for gas formation within the tissues, a hallmark of necrotizing fasciitis caused by gas-producing bacteria. The X-ray confirmed the presence of gas, and a subsequent CT scan provided a clearer picture of the extent of tissue involvement, showing widespread fascial gas along with edema. The diagnosis of necrotizing fasciitis, while clinically suspected, was further supported by the laboratory risk indicator for necrotizing fasciitis, LRINX score, which was calculated to be 8 based on the lab results showing a high CRP, elevated white blood cell count, and other markers indicative of severe infection and tissue damage. With the diagnosis confirmed, the patient was immediately taken to the operating room for surgical intervention. The surgical team performed extensive debridement of the necrotic tissue, which is crucial to manage this condition. Despite the aggressive medical and surgical management, the patient's condition required multiple surgeries and a prolonged hospital stay, highlighting the severity and aggressive nature of necrotizing fasciitis. This case underscores several key points in the management of complex skin and soft tissue infections. First, the importance of early recognition and suspicion based on clinical presentation cannot be overstated. Rapid progression of symptoms, especially in high-risk patients with diabetes or immunosuppression, should prompt immediate consideration of necrotizing fasciitis. Second, the role of imaging and laboratory studies in supporting the clinical diagnosis is crucial. While the LRINX score and imaging do not replace clinical judgment, they provide valuable information that can guide the urgency of surgical intervention. Third, the management of necrotizing fasciitis requires a multidisciplinary approach. Collaboration between emergency physicians, surgeons, infectious disease specialists, and critical care teams is essential to address both the surgical and medical aspects of the disease effectively as it gets more complicated. Finally, this case highlights the need for aggressive and early surgical debridement in conjunction with antibiotic therapy. The timing of surgical intervention can significantly impact outcomes, with delays associated with higher mortality and morbidity. Necrotizing fasciitis is a life-threatening condition that demands prompt recognition and aggressive treatment. As healthcare providers, our ability to quickly identify and manage such infections can be the difference between life and death for our patients.